great delight to introduce and welcome, virtually at least to Cambridge, Professor Mike Rinck. So Professor Mike Rinck is an associate professor at Radboud University Nijmegen in the Netherlands and an adjunct professor at Ruhr University Bochum in Germany. He was trained as a cognitive psychologist, and he was always highly interested in applied research questions. His main research area is experimental psychopathology. He studies biased cognitive processes such as attention, learning, memory, associations, and interpretations in various mental disorders. So more recently, he worked in the area of cognitive bias modification, which is the use of computerized training programs designed to retrain biased cognitive processes. His special area of expertise centers around assessment and modification of automatic approach-avoidant tendencies in various mental disorders. So welcome. Very glad to have you with us today. And perhaps we can start whenever you're ready.
Yes, thank you very much for the nice introduction and the friendly words. So as Nicolina just said, my area of expertise and my main area of interest is cognitive bias modification, and there particularly the modification and the assessment of approach avoidance tendencies. And this is actually what I would like to tell you a little bit about today. And in particular, the use of computer-based approach avoidance trainings in the treatment of alcohol addiction. And I try to make it a bit of a personal story by not only telling you where we are in this area, but also how we got there and where we should go, in my opinion. And of course, even though I'm giving this talk by myself here, this is work of a group of people, and a large group by now, actually. And during my talk, I will also introduce my collaborators. As I mentioned, the studies I would like to share with you today center around alcohol addiction. So let me first say a few words about alcohol addiction and dependence, what the size of the problem is. And I'm pretty sure you have heard many times that the problem is large. There's a high prevalence of alcohol use. There's a high prevalence of abuse and also alcohol dependence. And as we all know, at least the abuse and the dependence have serious negative effects on people's work, on their social life, and on their health. And regarding the latter, it is also related to a high mortality. Actually, I just learned, and I found that quite interesting, that every year we're losing about as many people to alcohol dependence as we lost per year to the corona pandemic. And everybody's talking about the corona pandemic, but how many people are talking about the lives we're losing to alcohol dependence? And what is also strange, actually, and hard to explain, is that there is also a very high relapse rate in abstinent alcoholics. So many alcohol-dependent patients manage to become abstinent, but more than half of them relapse into drinking again within 1 year. More than 60 or around 60% in Germany, and the numbers are pretty similar in other countries. And that is sort of confusing and strange, because once people have managed to stop drinking and are sober and don't have any symptoms anymore, why the hell do they start doing it again, knowing that it's very bad for them at a point where they have seemingly already conquered their dependence? And that's a bit what this talk is centering about. And part of the answer to this question, why do people start drinking again at all? Part of the answer comes from the idea that all behavior in humans, and also addictive behavior, is being controlled by two separate systems. And nowadays, we don't really view it as two completely separate systems anymore. But you can imagine that there's some sort of system that is what's more called the reflective system, and concepts like working memory, executive control, goals and intentions are subsumed under this system. So it's all consciously available, controlled processes. And the opposite is the more impulsive system, where we simply react to stimuli and where our brain sort of works on automatic pilot. And the idea, simply speaking, is that in addicted patients, the impulsive system is much stronger and controls the behavior much more strongly than the reflective system. And this can be seen in a number of different automatic processes, like attentional processes, where in addicted people, an automatic attentional bias can be observed towards alcohol-related stimuli, associations that are automatically evoked by the stimuli, and also automatic approach tendencies that are evoked by the stimuli, even though there may be intentions to avoid the stimuli. And if the impulsive system rules behavior more strongly than the reflective system, situations where alcohol is automatically approached and consumed despite the intention to not do so may be more easily explained than without this assumption. And basically in this talk, I will focus on two of these processes. I will speak mainly about automatic approach tendencies and a little bit about automatic attentional processes and how to measure and how to modify them. But let's first focus on the automatic approach tendencies. If we want to measure these automatic tendencies and then later on maybe even modify them, of course, it's a methodological question. How can we do that? By now, there are a number of different procedures and devices that can be used for that. At the time when we started developing these things some 10, 12 years ago, there was basically only one device that could be used to assess and modify automatic approach avoidance tendencies, and that was a joystick. So what we did in numerous experiments with numerous participants with numerous types of stimuli is have participants sit in front of a computer screen with a joystick in their hand, and we show them single pictures on the screen. And we ask them to either pull the joystick a little bit towards them, and then the picture increases in size on the screen. Or we ask them to push the joystick a little away from them, and then the picture decreases in size on the screen. And if the movement is correct, corresponding to the instructions, then the picture disappears and the next picture is being shown. And this combination of movement and the growing and shrinking of the picture, this zooming function, creates the subjective experience of pulling the picture closer versus pushing the picture away. And that's how we create approach and avoidance in this task. So that's a very, very general approach that basically can be used with almost any type of picture, sometimes even words, and a joystick. And when it comes to measuring approach avoidance tendencies related to alcohol, of course, we use pictures of different beverages, alcoholic ones and non-alcoholic ones. So for instance, on a black screen, the participants might see pictures of the beer cans. And when they push the joystick, the picture shrinks until it disappears. Or they might pull the joystick and then the picture disappears when the joystick is pulled all the way. And the same, of course, for non-alcoholic drinks that could be pushed away, or non-alcoholic drinks that could be pulled closer. That's the basic experimental setup. And this setup can be used both for the assessment of approach avoidance tendencies and for training and modification of these tendencies. And if we want to assess these tendencies, we have our participants push and pull all pictures, all drinks. So we ask them to do what may be compatible with their automatic automatic responses and what may be incompatible. They pull alcoholic drinks closer and push them away, and they pull non-alcoholic drinks closer and push them away. And we simply measure how long that takes. And we expect that incompatible combinations of movement and stimulus type take a little longer than the compatible combinations. And often, certainly not every time, but often this is indeed the case. If we want to use the same task for modification, for the training of these tendencies, especially to train avoidance of alcohol, we have our participants push the picture of the alcoholic drinks away all the time and pull the non-alcoholic drinks closer all the time. Usually we are not much interested in how long that takes. So of course you can use the reaction times to measure training effects, but what we are much more interested in is whether this has any effects on other variables, like for instance, consumption. So that's the basic setup with this task. And now I will mainly focus on instances where we had our participants do the training version of the task, where they mainly or sometimes even exclusively push alcohol drinks away and pull non-alcoholic drinks closer. So where are we? And a little bit about how we got there. Valerie and Nele will know this place. This is what I call my researcher's paradise. It's a clinic in the remote areas of Germany. It's always described as near Berlin, but that's actually a euphemism. It's kind of far out. The Salus Clinic in Lindau. And for me, it's really researcher's paradise, not only because it's a large clinic with many patients, about 800 or 1,000 abstinent alcohol-dependent patients each year, but also because it's combined with a great team of researchers that I'm happy to collaborate with. Among them, Eni Becker, my almost lifelong collaborator, Johannes Lindenmeyer, the head of the clinic, what's kind of rare, a psychologist and an extremely research-minded person, and Reinhard Wiers, colleague and friend from the University of Amsterdam. And basically everything that I'm going to show to you for the remainder of this talk is collaborative work that the four of us have done with a varying number of postdocs or PhDs and so on. So our very first study in this area was also conducted there. And as I said, the clinic is a large rehabilitation clinic. Patients come there after detox. They are abstinent, and the goal is to remain abstinent. And in Germany, the insurance companies invest quite a bit of money to help them. They stay there at the clinic for 3 months, and they receive mainly individualized cognitive behavior therapy, aiming to help them to remain abstinent. And of course, the idea is that the insurance company hopes that they will be able to enter the workforce again. The clinic contacts all patients routinely 1 year after treatment as a follow-up measurement. So luckily for our research, we did not have to worry about how to measure effects. The clinic measures the effects automatically by doing a follow-up measurement 1 year after treatment. On the other hand, it's only 1 year after treatment. So as researchers, we have to be patient. We conduct a study and then we wait for when the study is finished for 1 year until the last patient of the study has been contacted for the 1 year follow-up. Luckily, the clinic also, thanks to Johannes Lindenmayer, has an unusually high return rate. They reach about 80% of their patients after 1 year, which is much, much better than almost any other clinic that I've ever collaborated with. And what they find is the usual disappointing result that about 60% of their patients relapsed into drinking again after 1 year. And in addition to this usual procedure at the clinic, we were able at one point to add this joystick-based training of automatic alcohol avoidance. Ini and I had used joysticks or had done joystick experiments for years already. And Reinhard Wiers had introduced us into to doing that with drug-related stimuli, alcohol-related stimuli. And here suddenly we got a chance to do it in a real therapeutic environment and to find out whether such a training would actually have any positive effects for real patients. And in this first study, we did exactly what I just described to you. And actually, I also would like to show to you what such a training looks like and to give you a little bit of an experience yourself, what it feels like to be a patient in such a training. And unfortunately, I cannot do it individually. So I prepared a short PowerPoint approximation to the training to give you an idea what it looks like. It's not exactly the real thing, but it's pretty similar. And I would like you to join me in this demonstration by following the instructions and actually trying to pull pictures closer and push pictures away. Now, the instructions. What you will see is like a real patient, single pictures on the screen of drinks. And each picture is tilted slightly to the left or slightly to the right. So you are asked to respond to the tilt of the picture. And if it's a left tilted picture, you have to push it away. So please make a pushing movement with your hand. And you will see that at the same time you make this movement, I will make the picture shrink. So sorry, you're not really doing it yourself. We have to pretend you do. And if it's a right tilted picture, pull it closer, pull your hand closer, and I will make it grow simultaneously. And after that, the picture disappears and the next picture will appear. And don't worry, I won't take you through the 200 trials that a patient does in one of these training sessions. We will have about only 20 trials. So are you ready to move your hand? Then let's get it started. So this was right tilted, you had to pull it closer. Left tilted, you have to push it away. And so on for many, many trials. Okay, what you just experienced is sort of the training that the participants in our studies also experienced. As you may have noticed, there was a confound between tilt and picture type. You had to push away all the alcohol pictures, and you had to pull closer all the non-alcoholic drinks. And you may also have noticed that you didn't know all the drinks. This is, of course, something that shouldn't happen. So if I were to do this training really with British patients, I would have to choose British drinks that they know, of course, and that they consumed before they became abstinent. But the basic idea is exactly the same. You push away alcoholic drinks and you pull closer the non-alcoholic ones. And in this first study that we ran in Lindo, the general setup was like the one in all the following studies. So let me explain it once here, and then I won't have to do it again. The participants or the patients, shortly after entering the clinic, completed a pre-test of their tendencies with a joystick task that was an assessment task. So in this pre-test, they pulled and pushed both types of drinks. Then they were randomly assigned to one of 4 different training conditions, and I will explain in a second what these conditions were. If they were assigned to a training group, they received 4 sessions of training, which means 4 times 200 pictures. Sometime during the 3 months they were in the clinic, usually during the first month of their stay. And at the end of the 3 months, they received a post-test. So they were tested again with an assessment version of the joystick task to see whether their tendencies had changed over the course of training and treatment. And then we just waited for 1 year for the results of the regular 1-year follow-up. And in this first study, we compared 2 types of active training. One we call direct, the other one we call indirect, and I'll explain in a second what these were. And in both versions of this active training, they avoided alcoholic drinks by pushing them away, and they approached non-alcoholic drinks by pulling them closer. And then we had 2 control groups. One received what we call a placebo training. I'll show that in a second. And the other received treatment as usual, which means, of course, no training. Now, what did these 4 groups look like? The direct training group received instructions to always push away alcohol and pull closer the non-alcoholic drinks. And over the course of these 4 training sessions, they pushed away alcoholic drinks 400 times, and they pulled non-alcoholic drinks closer all the times, which may sound like a lot, but actually this was not more than 1 hour in total of training, and compare that to the 3 months they spent at the clinic. So it's a minimal additional intervention. And that's also the reason why we could do it. It was not much of a burden for the participants or the therapists to add this to the routine. The second type of active training, which we call indirect training, used a different instruction. So here the instructions asked the patients to push away landscape pictures and pull portrait pictures closer. But all the alcohol pictures were in landscape format and all the non-alcoholic drinks in portrait format. So basically they did the same thing. They also pushed away all the alcoholic drinks. Same behavior, only a different instruction for this group. One of the reasons we incorporated this group is because the indirect instructions have a few practical advantages. And here in this study also, one of the important features of this of the indirect training is that we used exactly the same instructions in the placebo training group, the control group. They also were asked to push away landscape pictures and pull portrait pictures closer, but here 50% of the alcohol pictures were in landscape format and 50% in portrait format, and the same for the non-alcoholic pictures. So basically, they had the same task with the same equipment, with the same pictures, but there wasn't no training aspect. It was basically a really long extended assessment version of the task. And then the fourth group, so these people also pulled alcohol pictures closer. And then there was a fourth group, the no training group, that only received the pre-test and the post-test like the other three groups. We investigated how this affected their craving, how the tendencies changed over time, and how it generalized to associations. But the most important results were only became obvious a year later, when we were able to look at the complete set of relapse data. And then, much to my own surprise, I must admit, we discovered what's shown here. And when you look at the red bars, which indicate the percentage of patients who relapsed 1 year later, what we found is that the two training groups, the direct training group and also the indirect training group together, had a significantly lower relapse rates than the two control groups. A significant reduction in relapse rates by means of this very minimal intervention, this ridiculous little joystick thing, the game task, you might call it. Hard to believe. So I wouldn't blame you if you wouldn't believe it either. I had problems believing it myself. So this was definitely in need of replications. And much of the rest that I want to show you now are replications. So in a second study, we aim to replicate these results, or if we cannot replicate them, bury them forever, and also try to predict who would profit from the training, because obviously not everyone does. There was still 50%, almost 50% relapse. And in the second study, we only compared two groups to each other because we wanted to be able to increase the sample size per group. And since the number of patients and the number of computers and rooms and time slots are limited, we compared only the participants receiving the indirect training to patients that did not receive training. And seeing that 4 sessions of training helped, we aimed to increase the effect by giving the patients 12 sessions of training. And that also created a limitation, because if each patient now does 12 sessions instead of 4 as before, it became obvious that we cannot train a large percentage of the patients. So we reduced, as I said, the number of conditions, but at the same time also increased the number of patients per group, because we realized that the effect is small, statistically speaking, and we need more power to find it if it is there. And more power, the way to achieve it is by larger sample sizes. So what we found, also again, somewhat to our surprise, positively surprised that the effect was there. It did replicate, it was significant again. However, it was not larger than before. It was actually a little bit smaller. It was 8% difference, which actually turned out in the long run to be more realistic than the original 30%. And on top of that, when we looked for predicting factors for the effect of the training, we found, when we looked at a number of predictors, that they all converged on something that is luckily very easy to measure, and that was age. Older participants in this study profited more. For the older patients, it made a big difference whether they received the training or not. And for the younger patients, it did not. And younger in this group means between 30 and 45, actually. Now, of course, age per se doesn't really explain anything. But age was related to a number of other variables, like executive control, number of drugs being consumed, and other factors. And all these together were related to age. And that's why in the regressions we used, age came out as a very simple predictor, because it subsumed all the other factors that may be important. So that was a first very encouraging replication. Before we had the results of this study, we had already started a second study, a third in this case, a second replication study, where we were interested in the role of comorbidity. And since we hadn't learned yet that 12 sessions didn't really do better than 4, we still had 12. Nowadays, we know that it's not necessary to train 12 times. Now our standard procedure is 6 times. But okay, at that time, we didn't know it. So again, we had a large number of patients, more than 300, who received 12 sessions of training, and an even larger number of patients without training. Again, the difference was there. It was significant. And here it was 10% less relapse in the group of patients who had received our training. And that was also quite encouraging, when we looked at patients who suffered from a comorbid disorder, then we found that this did not reduce the effects of the training. Almost all the abstinent alcoholics in the clinic also smoke, so are addicted to nicotine, and it did not matter, it helped nevertheless. A number of them were also diagnosed with an anxiety disorder or with a depressive disorder. And even for these patients who are usually considered more difficult, and patients who usually have higher relapse rates than alcohol patients who do not suffer from an anxiety disorder or depressive disorder. So even though the overall risk of relapsing is higher, still the training reduced that risk also significantly in these two groups, which was a very nice result, because it showed to us that it's still difficult for us to predict who will profit, but we know that it will not only help patients who are the easier patients, if there are any in this group. And now the next study I want to show you, and that's the last one I want to show in detail, introduced a second type of training, because by then we were convinced that our training does really work. The rest of the world wasn't yet, but at least we were. So we were starting to look for improvements. And in Reinhard Wiers' lab, they had encouraging results with a different type of training, a training of attention processes instead of approach-avoidance processes. So our idea and our goal was to find out whether an attention training would also help the patients to reduce relapse. And maybe if we combine 2 different trainings and train 2 different processes, this would help the patients even more. And to train attention, we used the task that was the sort of standard task at that time to train attention, the so-called dot probe task. Our version was slightly different from the standard version, but it was still a regular dot probe task. And in such a task, what you do is you present 2 stimuli. In our case, of course, always an alcoholic beverage and a non-alcoholic one. And you try to train participants to focus quickly on the non-alcoholic drink. And the way to do that is to give the participant a task that becomes easier if they focus their attention on the non-alcoholic drink. And in the dot probe task, this is done by showing these two drinks only very briefly, half a second, and then making them disappear automatically, and then replace one of the two drinks with a target stimulus that they have to respond to. And in our case, this target stimulus was a little letter, and the letter indicated how they had to respond with the joystick. And this is where our task version becomes a little unusual, because normally you would just press a button on the keyboard, but we wanted our participants to also use the joystick in this task. So when the little letter was a Z, as the first letter in the German word ziehen, which means pull, they had to pull the joystick. And then the picture would disappear without growing or shrinking. So we did not include anything related to approach avoidance. It was just that the letter indicated how they would have to react. It could just as well have been an instruction to press one of the keys on the keyboard. Another example, here again, a non-alcoholic drink and an alcoholic drink. They appear very briefly and disappear. And here then the non-alcoholic drink would be replaced with the letter S, which is the first letter of the German word schieben, which means push. So here they would have to push the joystick and then the picture would disappear. So this task also uses the joystick, but there is no connection between the type of picture and the response. They push and pull the joystick with both alcohol and non-alcoholic pictures. And how they have to respond is indicated by this little letter. And since the letters in the training version always replace the non-alcoholic drink, the goal is, and it has been shown in other areas, mainly in anxiety trainings, that it can work out. The attention is trained away from alcohol and towards non-alcoholic, because it's easier to see the letter quickly and respond quickly if you're already looking at the drink that will be replaced by the letter. And if you're learning, and even patients learn that fairly quickly, if you're learning that the letter will always replace the non-alcoholic drink, you may also overcome your tendency to always look at the alcoholic drink and learn to look at the non-alcoholic one and focus your attention on that and then respond to the letter. That's the basic idea of this attention training. So then in this really big study, which ran for 2 years, the data collection ran for 2 years, and then there was a third year waiting for the follow-up data. Same setup as in all the other studies, but now 6 different training groups. One group received our general avoidance training. And here we call it behavior avoidance because it involves the pushing away versus pulling closer of drinks. 238 patients did the sort of training that we had done before several times. 230 patients received this new attention training where their attention was trained away from alcoholic drinks. And both groups received 6 sessions of their training. And then there was a group that received the combined training. They received 3 sessions of the behavior training, followed by 3 sessions of the attention training, or counterbalanced the other way around. And then control groups. There was a control group that received placebo training. And actually, these were 3 different control groups, either receiving only the placebo version of the behavior training, or only the placebo version of the attention training, or only the placebo version of the combined training. Spoiler alert, this did not matter, so we aggregated the 3 groups into one group of 316 patients. And then a control group of 366 patients who received no training at all, just as it was at that time training as usual, treatment as usual without such a joystick training. Again, the most important result were the relapse rates 1 year later. And good news is we did observe and we did replicate the training effect. The 3 active training groups, the 3 bars here on the left, on average had a relapse rate of 47%, whereas the 2 control groups, the placebo training groups and the no training group, had an average relapse rate of 54%. Again, statistically speaking, a small effect. Financially speaking, a large effect, and of course for every single patient who remained abstinent, a large effect. What we did not observe is a difference between the 2 control conditions, nor a difference between the 3 active training conditions. I had hoped that receiving both types of trainings would reduce relapse rates even more than a single training, but it did not. Maybe that's because the patients who received both trainings only received 3 sessions per training. So maybe 3 was too low a dosage for an effect on relapse rates. So on our list for the future is a study that actually gives patients 6 + 6 instead of 3 + 3. In this first study, it was important to keep the overall number of training sessions constant. This is why we chose for 3 + 3 in comparison to 6 of this and 6 of that. But again, an encouraging small effect on relapse rates. Now, to summarize the main clinical results from this series of studies, while leaving out a few studies that we also did, is that this training of the automatic alcohol avoidance tendencies actually works. And unlike many other modification techniques that we are investigating, and not, of course, not only our lab, but many, many colleagues around the world, unlike many other trainings where we're still trying to find out if and how it works, here we actually already know that it works. And on average, the reduction of the relapse rates observed after participation in such a training is between 7 and 10%. We know that the training works better for some patients than for others. We find it very, very difficult to predict for whom. So currently, everybody's receiving the training because we are just not able to tell a patient, no, we know for sure you will not profit from the training. So every patient receives it in Lindo and by now also in many other clinics. But luckily, we know that the training also works for what's often considered difficult patients with comorbidity. And we recently finished writing up a study where we also saw that it works in sort of everyday clinical situations where the training was implemented in 10 other clinics in Germany. So that's also encouraging. There's some evidence that an attention training may also be helpful, but the evidence is much more limited than for the joystick avoidance training, but it's definitely worth investigating this further. In addition, in the meantime, the relapse prevention effect has been replicated in 2 Australian studies led by Victoria Manning, which was wonderful news for us because it shows that it's not our own sort of doing the studies, way of doing the studies that helped. Their implementations of the training were slightly different from ours, but it reduced relapse rates at least as much as it did in our studies. And this has also led to a rare case for CBM procedures, namely to implementation. The training is by now included in the treatment guidelines, the official treatment guidelines for alcohol addiction in Germany and in Australia. Strangely enough, not in the Netherlands, where the researchers come from, mainly who do the research. So this is also an interesting question. Once you have something that is helpful, how do you get it implemented? That's quite a different story. And so this is where we are, I think, and a little bit of how we got there. What remains to be done? Yeah, a lot. There are so many questions that we haven't answered that and that are worth answering. Some of these include, for instance, what is actually happening during this training? What are the working mechanisms? We are trying to use the reaction time data from the training itself. We have 2 fMRI studies that give some hints at what is changing during the training. We have done a little bit of EEG studies, but actually we are far from knowing exactly what we're doing. We know the training helps, but exactly why and how still remains to be determined. But I guess that's true for many treatments. How can it be improved further? That's for us right now the most important question. And part of an answer to this question actually comes from your group, where Valerie and Nele did a really nice study using a gamified version of the training to motivate patients to continue with the training after they have left the clinic, which we also tried many years ago and failed miserably. We gave patients the opportunity to continue the training after they had left the clinic. They seemed highly motivated and nobody did it. Just very few patients did more than 1 training session. And I believe Valerie and Nele found the trick to motivate patients to continue the training afterwards. And then it could also be used as an online training. In terms of equipment that is needed, it can be nicely done online. For instance, the pandemic forced me to do online studies over the past 2 years. So since nobody has a joystick at home, I had to do studies where people use the mouse to push away pictures and pull them closer. And that seems to work nicely. So that could be used, for instance, to have participants do such a training at home. And if they are motivated to do it in this clever way that Valerie and Nele developed, then they might actually be willing to do it. We're also investigating combinations of this training with other trainings. The study that I showed to you, combining the avoidance training with attention training, is one example of that. And there are many, many other ways that might be considered trying to improve the training. What we actually cannot do anymore at the clinic in Lindo and in many other places is use a placebo version of the training. And we are sort of haunted by our own success. Since now it's clear and evident that the training is helpful, we cannot withhold it from the patients anymore for ethical reasons. So we are now not only interested in doing, we are also forced to do what's on our list, namely to look for improvements, but not to investigate the training itself by comparing it to a placebo version. We can always use placebo versions of new trainings, because no one knows whether the new trainings are really helpful, but with the existing training, we cannot withhold it any longer from the patients. Then, of course, the situation that I have shown here is a very, very limited one. It's in patients, and our goal is to prevent relapse. Now, obviously, this is just one very particular situation of many possible ones that would be important. So an important question would be, can we use such a training to stimulate reduction of consumption or to stimulate abstinence? Can we motivate people to quit drinking, for instance? I don't know. We have never been able to do such a study. And then, of course, you might immediately be thinking of other disorders where such a training could also be helpful, especially other addictions. And there's quite a bit of research by now on smoking. And the results are far less encouraging as they are for alcohol. One of the reasons may be that most of the smoking studies try to stimulate reduction or abstinence, and they are not done with smokers who just made a quit attempt where the training is aimed to help them remain abstinent, as in our alcohol studies. Cannabis has also been tried with little success, as far as I can say, probably mainly because of little motivation to really quit consumption. Also, surprisingly, quite a bit of success in depression. The training looks completely different then. It's also an approach-avoidance training with the joystick, but the stimuli are quite different. And it does seem to help reduce depressive symptoms over and above treatment when it's done as an add-on to treatment, like our alcohol trainings. And very mixed results with regard to obesitas, when of course, then your goal is to push away high-calorie foods, for instance. So with that, I would like to thank you very much for your attention. And I hope I did not speak too long, and I hope we do have time left for questions. Thank you very much.
Thank you so much for the very interesting talk and the very impressive results and cohort of patients. That is a huge number.